Hi, everyone. Welcome to Flash Talk Parallel Track 3, I think. Today we'll be hearing 4 presentations on integrating digital services in healthcare, school, or other systems. Really excited to see all these presentations and hear some awesome questions from the audience. We'll have about 5 minutes per presenter and then an additional 5 minutes afterwards for Q&A. Feel free to raise your hand, unmute yourself, pop questions in the chat, sort of however it goes. We're a small enough group that it should be manageable. And with that, we can go ahead and get started. Nate, you're up first.
Thank you. I will go ahead and share screen. Can folks go ahead and see my screen?
Yep, we're all good.
All right, super. So I'm going to go ahead and start. Today, I'm going to be talking about advancing schizophrenia treatment using a modified Delphi consensus technique on the critical role of psychiatric pharmacists in prescription digital therapeutics. There we go. These are disclosures. I am a consultant and I do receive honoraria from Boehringer Ingelheim Pharmaceuticals, and I have other roles in the community. Also, my co-authors, Ravi Patel and Smit Patel, have received honoraria also from Boehringer Ingelheim. And then just a few other points about the criteria that we use for authorship and so forth. So in where I really want to hit home is that psychiatric pharmacists do have a unique and pivotal role in supporting the adoption and utilization of prescription digital therapeutics by patients with schizophrenia. And many of you may already be aware that prescription digital therapeutics are software-based interventions that are used in managing and treating medical conditions prescribed by healthcare providers and dispensed by pharmacists. The thing to note also is that these prescription digital therapeutics are subject to FDA authorization, requires demonstration of clinical effectiveness and adherence to post-marketing requirements. Boehringer Ingelheim is working on such a tool, and that kind of inspired some of the work that we did. The use of prescription digital therapeutics by people living with schizophrenia does appear promising by some reports. Although you can imagine that there is some concern due to limitation of digital literacy, economic barriers, and challenges associated with the integration of digital health tools. So ultimately, this comes to a set of aims here where we wanted to really develop recommendations on how psychiatric pharmacists can contribute to the use of prescription digital therapeutics by people living with schizophrenia by determining the role of, in particular, psychiatric pharmacists as advocates for scaling and embedding prescription digital therapeutics for schizophrenia treatment within existing healthcare systems. And I say that broadly, even in community pharmacies as well, highlighting how pharmacists can broaden access to prescription digital therapeutics for schizophrenia and encourage patient engagement, and identifying assistance pharmacists can provide so they are point of care for people with schizophrenia with prescription digital therapeutics as well as their caregivers. So how did we go about this? So we used a modified Delphi methodology. And, this is essentially, we use 3 steps to do this, and we'll sort of talk about that. So the first step is we did some background work, research. We identified a steering committee of which I was a member of, because by the way, I didn't introduce, I am a psychiatric pharmacist, as well as a faculty member and associate dean at the UConn School of Pharmacy. And so I've had an interest in digital health for a number of years. We used this IRB approved consensus framework. This was IRB approved. I would say that we focused on scale and access, and data wasn't a focus of this particular work. but essentially how pharmacists can support the integration of PDTs for patients with schizophrenia. By the way, I may now refer to PDTs as, prescription digital therapeutics going forward. How pharmacists can help patients with schizophrenia access PDT. And we developed a number of questions at 56 open and some close-ended. Well, there were some open and many of them were close-ended. We used Likert scales, ranking exercises, and multiple option questionnaires. In the second step, we then identified a larger group of people who really comprised of those who were trained pharmacists in the US. They had experience in mental health, psychiatry. They represented a diverse group of pharmacy stakeholders, and some of them had experience in using digital therapeutics in mental health. There's a few prescription digital therapeutics that exist presently on the market, and they had an interest in prescription PDTs. And so we actually administered the survey to this group of 10 experts. And then in the last step, we all came together, the experts and the steering panel, and things that required consensus. We basically, if the step 2 yielded scores of 6 or greater out of 10, we kind of felt like they had consensus. And then those that didn't, and even those that there was consensus, we just had a very rich conversation, and we had a lot of conversation about some of the differences in opinions, and then we had another vote and so forth to get to consensus.
Just so you know, you're at 5 minutes.
Wow. Okay. All right. I will try to wrap up as quickly as possible. The quantitative findings are in summary statistics, and then we did thematic analysis. This slide is not too critical, so we probably will go through this quickly. Many of the experts were psychiatric pharmacist specialists representing academia and other areas of pharmacy. Some were at least somewhat familiar with PDTs and had been using PDTs for different conditions. So I think out of the next couple of slides, which will really hit home the main points, is that we have where pharmacists really were motivated by having an impact on patient outcomes and actually co-monitoring drug therapy and psychotherapy treatment. And I know someone else is presenting on cognitive behavioral approaches to using digital therapeutics, and this would be that opportunity to watch drug treatment along with psychotherapy and looking at them together. Here we see that pharmacists really see the value of educating patients and improving engagement with the PDTs. Being partners with the clinicians and prescribers was viewed as very important. Obviously, a very critical challenge in the whole enterprise is prescription coverage and reimbursement. So access, all pharmacists thought they should have a role in identifying patients that would be eligible. Again, education would be an important part of engagement, which is, by the way, a key role for pharmacists these days. But they also note that pharmacists anticipate patients will lack trust in this new model of care, where involved training, awareness, availability of time, and those would be common barriers. And again, in this next panel here, basically pharmacists could have a role in using PDTs in both an outpatient setting, starting them as they're getting discharged from the hospital, and really monitoring treatment progress all the way through. So on our last slide here, we see that just main conclusions. Pharmacists believe the biggest impact on PDTs for schizophrenia will be patient education engagement. Improved patient outcomes was among the top motivators for adoption of PDTs for schizophrenia. And again, those coverage and reimbursement being key barriers. And on the access part, increasing the number of pharmacists identifying patients would likely help broaden the adoption of PDTs. Engagement of patients with schizophrenia for PDTs may be done during these different phases of care. And then common barriers of engaging patients would be trust, training, and time. The limitations are well known: small sample size, not validated survey measures, and the lack of experimental controls. I think the most important future direction is real-world evidence pilots to show that psychiatric pharmacists can actually put this in place with prescribing, dispensing, and monitoring PDTs for advancing schizophrenia treatment. So I will stop right there.
Great, thank you so much. Also, I just found out that our fourth speaker is no longer part of the conference, so we have plenty of time to to not feel rushed in your presentations and lots of time for questions. So did anybody have any pressing questions for Nate?
I'll stop sharing. Maybe that'll be a good thing so we can see faces. I would imagine many folks may not even know what a psychiatric pharmacist is or what they do. And we are just a trained small cadre of pharmacists in the larger pharmacist community where we have gone through residency training and we have specialized training in mental health. I've been a psychiatric pharmacist for now over 20 years.
No, I found it really helpful to get the perspective of the pharmacists and trying to implement some of these treatments. I do a lot of the passive sensing work and have an interesting time thinking about using it in populations like folks with psychotic disorders, and what it would be like to try and explain the utility perhaps of collecting all sorts of data and how that would be received.
Yeah. I will say that we are working. So one way to make this happen is through collaborative practice agreements. So this is where a physician and a pharmacist work together and they have a protocol. And the pharmacist has to follow that protocol. But essentially would be for said patients that are interested in using the PDT, please get them set up, get them engaged, and basically set up a protocol around notifying the physician and or the therapist about the data that you're getting and people's use of it, adherence, and so forth.
Definitely. All right, well, thank you so much, Nate.
Sure. Thank you.
Next up, we have Cassandra's presentation.
I'll share my screen. Okay. So hello everyone. Thank you guys for joining us today. My name is Cassandra Lugo, and I'm a clinical research coordinator for the Supera study at the University of California, San Francisco, under the Digital Health Equity and Access Lab at UC Berkeley. And today I'm going to talk about the training process our peer supporters or Apoyadores went through for our study and the themes that came up throughout. So why do we even care? It is known that Latinx patients with limited English proficiency experience a high prevalence of depression and anxiety and longer duration of untreated mental health disorders. When they do receive treatment, providers lack linguistic and cultural competencies, meaning that they tend to receive lower quality of care. Depression and anxiety evidence-based digital interventions have been proven easy to disseminate, but then the engagement is often low. Our study wanted to combat low engagement by leveraging peers. We are evaluating the effect of peer support with an evidence-based Spanish language digital cognitive behavior therapy intervention named Silver Cloud in safety net primary care clinics, specifically with LEP Latinx patients with depression and/or anxiety. Pictured here is the Silver Cloud app that we use. There are 7 modules that participants work through during an 8-week intervention period. Some background on our supporters. Somos Esenciales, a community organization formed during COVID to provide the mission neighborhood community welfare, and they did a PAR research work identifying mental health resources as a need. Somos Esenciales is composed of 11 Latinx mission community members and 2 leads, ranging from 30 to 60 years old. These members are not mental health professionals, but they are known to be engaged community figures. We recruited them purposely for their need and previous work in the community. And pictured here are our current supporters. So from January 2023 to June 2023, we trained the 11 members during recorded bi-monthly meetings. It is important to mention that the research and training team is composed of multicultural and bilingual staff. And so during these trainings, we taught the group about mental health psychoeducation. We reviewed the content of Silver Cloud and how supporters were interacting with the app. And we touched on the basics of peer support and how that work would look like. The recordings were transcribed and used as our qualitative data. This is still preliminary data in which 2 of my coworkers and I are currently coding through and deduce. We've used inductive and deductive methods to create our codebook by reading through all the transcript and then using the integrated promoting action on research implementation in health services, or IPARS framework, to finish making the codebook. Some of the major themes have been related to the supporters' baseline skills and training process as a whole, technology and engagement with the app, and then determinants of the intervention like feasibility and perceived fit. First, we've identified community members' baseline skills and knowledge and barriers we faced. Our members' baseline literacy for tech and psychoeducation was pretty low. We planned to start off with CBT methods, but instead, during the first meeting, Ali told the research team, but perhaps the first thing is how accustomed they are to using apps. And for what? Well, to communicate with friends. So that let us know that we had to pivot with more basic topics like apps that they've used and build on the skills that members already came with. Being a digital intervention, themes of technology are prominent. We've identified barriers and engagement with the intervention. When asked about technology, a supporter stated, "We're not used to it. We only started out of necessity. We figured it out because we have to, but we're not accustomed to it," which is most likely why our Latinx community began using tech out of need and not curiosity. So the use of tech was limited. Lastly, supporters' feedback was important. Were they finding the intervention to be a good fit or compatible for their community? As supporters stated, so the app, in my opinion, is going to be very helpful for our community, not to solve the problem, but to see how they can manage the situation and how they can find ways to mitigate what they're going through, highlighting their belief that the intervention will help their community as we intended. In conclusion, we learned to assess supporters' baseline literacy for tech and the intervention, etc., to understand what to focus on during these trainings. We started with what depression and anxiety is, and now they use CBT methods to help themselves and their community. We also provided lots of extra support with tech, from teaching them how to log into the app and navigate the internet. Their skills have developed so much that they sometimes provide support from home instead of in in-person meetings. And having supporters evaluate the intervention throughout their training proved useful. The vignettes, or personal stories, in Silver Cloud initially did not reflect them and their community, so we changed it, and our participants have stated that it's a favorite feature. So understanding the barriers and how supporters engage with the app can then inform others how to train peer supporting Latinx professionals, and can hopefully improve digital mental health interventions. That was all I had for you guys today. So if there are any questions, I'll stop sharing as well.
Any questions for Cassandra? I have like 5,000. I'll keep it contained. This is really cool work, like very, very relevant to a project that my team's been working on and really struggling to recruit folks and be able to get their feedback on our application. I have many questions that I could ask. However, I'll keep it contained to, I guess, how do you plan on like ultimately disseminating this more broadly in the community? It sounds like this project's really working with the peer supporters. And so how do you envision their role in the next step of disseminating within the community?
So we are currently already recruiting, and we're actually trying to add an exploratory community arm where we're planning to go and outreach into the Mission neighborhood community by going to like food hubs or other community organizations and doing either flyers or word of mouth or having just like an entrance form there for them.
Was the data collection already happening before you introduced the peer supporter kind of approach?
No, so we trained them before we started our
Okay.
recruitment.
Very
Yeah.
cool. Question in the chat, is there a particular model to capture feedback from peer supporters on their training?
So we didn't actually like have that in mind. We just recorded the training sessions, but we didn't like set it up in a way that yeah, was to get feedback from them. We just like during those training sessions would ask them like how did they like the intervention? That we had them like go through the intervention themselves, kind of like unsupported, just so that they understood the content and what they were going to ask other participants to do. So yeah, we didn't really have a model to capture that feedback. It was just like naturally from when we were training them.
Very cool. And you kind of hinted at this, but I'm familiar with Silver Cloud is like an off-the-shelf kind of app that you can purchase or that works, I think.
Yeah, I don't know if it's available here yet. They did have it, I think, in the UK and in Mexico. And
Okay.
there's currently doing studies in Mexico as well with them, with like college students. So
Okay. It sounds like
Mhm.
you were able to customize some of the content to have a better
Yeah,
fit. Okay, that's really
yeah,
interesting.
definitely. The personal stories, um, like I said, they are doing a study in Mexico and it's more targeted towards college students. And so with our kind of the recruitment that we want to do, it was geared more towards like adults and not so much college students. So we wanted to make sure that they were reflected in that.
Very cool. I'm
Mhm.
excited to follow how this pans out and maybe poke your brain a little bit at
Yeah.
another time about how we can fix our own recruitment issues. But any other
Yeah.
questions for Cassandra? Great. All right. Well then,
Thank you,
Sam, you're
guys.
up. Feel free, folks, to continue brainstorming questions for yourself because we will most certainly have plenty of time for additional questions for all three of our speakers at the end.
Okay, well, thank you for having us. And we're presenting today on digital CBT for substance use. We did a systematic review and meta-analysis of randomized controlled trials. I am Dr. Sam Wolf Taylor, and I am joined by my colleague and peer, Dr. Virgil Gregory. Both of us are very passionate and interested as it relates to using CBT online in telebehavioral health practices and researching the effects of those services that are being provided. There's a little bit more info there, but I'm going to breeze through it so then we can talk about why we're here. So, why digital CBT matters now? Ultimately, there's 48.5 million Americans battling a substance use disorder in the past year. We also know that substance use continues to affect adults at alarming rates. We also know that there are a lot of barriers to in-person treatment care. This isn't anything new, but something that we should remember is stigma, provider shortages, and geographical isolation still limit access to care for a lot of patients for mental health. We also see digital CBT emerging as a timely solution to these concerns, but we need data to guide us. And we're seeing a lot of changes come about. AI transforming care delivery, social media shaping our behaviors, and political uncertainty playing major roles in our mental health and how we receive mental health. And we also know that only a small percentage of individuals with substance use disorders access evidence-based treatment. So this is why CBT matters, and I'm going to pass it on to my colleague, Virgil, so he can talk about our study.
All right. So our inclusion criteria was fairly broad. It was for adults only prior Unlike prior meta-analyses that were for nicotine and alcohol, we included both alcohol and drugs. The experimental arm was required to receive a digital CBT, and they were required to have used cognitive restructuring or used a manual that reported using it. We didn't have any particular control group other than requirements, other than they could not use the CBT intervention. So it could have been treatment as usual, could have been an active treatment, could have been wait list. So it was very broad. The outcomes were a biological sample or a self-report measure. If a study used both, then the biological sample was used as the outcome for that randomized control trial because the biological sample was believed to have less bias. The study designs, we only included randomized control trials. We did 2 meta-analyses. The first 18 studies met our inclusion criteria. We used a random effects model because there were anticipated differences in the interventions and the populations. So for that reason, we used a random effects model. But what was interesting is that both the random effects model and the fixed effects models were exactly the same. So that means that we basically had a homogeneous group of studies, with the exception of one outlier that you can see at the top of the forest plot that had a particularly small sample size, a big effect size, and it was an outlier. So after we removed that one outlier, we had a fairly low I-squared to begin with, but even after removing it, it reduced even further to 5.34. And in both meta-analyses, the studies that were pooled were homogeneous. So we had a small, statistically significant effect size that favored digital CBT relative to the control groups. So publication bias was not an issue. The randomized control trials were effect sizes were fairly symmetrical around the mean. Our studies were homogeneous, so it was appropriate to use Egger's regression to evaluate publication bias, and that was statistically insignificant, suggesting a lack of publication bias. So we had homogeneous effect sizes. We had small, statistically significant effect sizes a small statistically significant overall effect that favored digital CBT and minimal publication bias.
So we're going to talk about the implications of this. So, why does this matter? Well, we know that digital CBT can help bridge care gaps for marginalized and disconnected populations. It also promotes ethical AI development and aligns with the shift towards mobile first, asynchronous, and personalized care for clients in need. It also offers a proven foundation we can build on with responsibly and ethically. And it isn't just about clinical effectiveness, it's about equity and innovation and how we provide mental health services for SUD. Moving forward, some things to think about. While it's promising, digital CBT must be developed and deployed with care. We also know digital CBT needs to be trauma-informed, culturally responsive, and accessible to diverse users. And it needs to be designed not as a replacement, but as supplements or bridges to human care. It's an opportunity now to scale what works and blend it with emerging technologies and continually evaluate outcomes in the real world context. So in conclusion, this research confirms that digital CBT is not hypothetical, it's effective in SUD treatment and care. As we work to meet the challenges of this moment, as we talked about evolving technology, changing futures, we certainly need tools like digital CBT that are evidence-based, flexible, and equity-driven. And we'd like to open up for any questions you might have. And thank you for joining us.
Thank you, guys. Any questions to start us off? Oh, question in the chat. Anything about the diversity of the populations that were assessed in the studies?
There were not a lot of, if you're referring, diversity could be so many things, but if you're referring to race, there were not a lot of Black people. So that's one of my areas, is structural racism and its intersection with cognitive behavioral therapy. So no, there were not many Black people at all. There were a few randomized controlled trials that had some. There were not many Hispanics either, Hispanic samples either. Most of them were predominantly white. There's lots of other types of diversity, but those are two.
Dr. Gregory, did you see also urban and rural populations assessed?
I don't. I think there was not very many rural, to the best of my memory. There was not very many rural. And a lot of them were from Judith Beck's CBT for CBT. So a lot of them were in more urban areas. So definitely not as much rural. But yeah, I mean, totally makes sense because digital CBT would be great for rural areas where there's usually a lack of providers. So that totally makes sense. Great question. Thank you.
Thank you.
I was curious about the range of control conditions, because you mentioned that it could basically be anything that was non-CBT, and so treatment as usual, wait list. Were there any other like active interventions that were being used that just happened to not be CBT?
So I have the study right here in front of me. So I'm just going to look at some of the control track types. So most of them were treatment as usual. We had a couple that were wait list, and then we had a few attention placebo, but there were no active treatments. And then if they use another CBT, that was against our inclusion criteria. So they could have used something else. It just couldn't be a CBT oriented approach. But most of them were almost always treatment as usual. And then after that, it was wait list. And then after that, it was attention placebo. But
So I don't tend to do substance use research. What sorts of care would fall under treatment as usual?
So that would be like seeing it might be seeing a medical doctor. For example, if somebody's on opioids, it might be getting a medication for opioid use disorder. Could be group therapy, it's like a support group. If they would have had 12-step facilitation or something like that, that might be in there. But some of those treatments had a medication like pharmacotherapy, and others were just like supportive counseling.
Okay.
Yeah. I will say this too. I was really surprised with the study because as you mentioned, Taylor, they were heterogeneous studies. Like we didn't control for the type of control group, but when we analyzed the effect sizes, they were homogeneous, like even with the 18, but that one outlier was such an outlier. Um, it was way off. It was not within the 95% confidence intervals of the other effect sizes. So we took it out, and then we had an even more homogeneous pool of studies. And maybe I'll just throw one more thing in there also. Our study looked at alcohol and drug use. And I think sometimes people have the perception that alcohol is different than drug use, but we used a common structure of mental disorders approach where alcohol, drug use, they have an underlying basis of lack of control or impulsivity. And so that was the kind of framework that, or the theory that, or the framework that we use to combine those different studies. And as you see in the heterogeneity statistics, it was appropriate because all those effect sizes came from the same population.
That's all very, very interesting. We can also open it up to questions that we might have had for our first two presenters as well. As folks have had time to percolate information. Carmen read my mind thinking about behavioral addictions. Yeah, so if thinking about the underlying mechanism as being sort of like an impulse control type of disorder, do you anticipate seeing similar effect sizes for things like gambling or I don't know, compulsive shopping or something?
That is an excellent point. It totally makes sense. So then why didn't we just include like gambling and other? No, that totally makes sense. I think we also cited covariant structural analyses that like structural equation models or confirmatory factor analysis that showed that there was a common core. So we didn't. Um, but given the framework that we use, it would have totally have made sense to do that. I'm sorry. And then who knows? I'm kind of inclined to say maybe, maybe not, but I mean, based on that theory that it's all under control or impulsivity based things, maybe we would see it. Maybe we would, have still have a homogeneous pool of randomized control effect sizes from randomized control trials.
I really enjoy thinking about like the delineation between substance use disorders and some of those behavioral addictions, if they're fueled perhaps by the same sort of troubles with impulsivity or troubles with emotion regulation. Yeah, I guess like how wide of a net do we want to cast in trying to understand sort of what's contributing to these problems?
Yeah, that is very consistent with the transdiagnostic approach. So some people will treat CBT for like one CBT for all of the anxiety disorders. Norton does that. Yeah. So.
For the two of you, there's a question in the chat for whether you looked at the dose of CBT within the studies and whether that had a role in effect size and the outcomes that you saw.
We didn't, but because all of the the I square was low, and then the Q statistic was statistically insignificant, there was no empirical reason for doing so because all of the effect sizes were more or less so close together anyway. But yeah, it totally makes sense. But I believe in table 1, we did look at we did document the length of treatment, and we could have, if we had heterogeneous studies that suggested they were from different populations rather than one, we could have used a meta regression to see if the effect size in each study was related to the amount of treatment. But there was no need to do it because our pool of effect sizes were homogeneous.
I always find that so interesting. Like what's the minimal amount we can get away with to have some lasting impact on users? There's another question in the chat going back to Cassandra. Did you have the questions you asked the peer support workers? Like, was any of it structured or was it all just occurring naturally within the training sessions, the types of questions you were asking?
Yeah, it was definitely a lot more naturally while doing check-ins with our supporters. So we really didn't have like a method to it. Yeah, definitely a lot more organic. Mm.
I'm thinking about the fact that the theme for this particular session is integrating digital services in healthcare, school, or other systems. Cassandra, remind me how, I guess your other system is like peer supporters, but what's like the dissemination pathway look like for reaching individuals?
So we have two arms. We have inreach and outreach. So outreach is just basically like a list of participants or patients with our inclusion and exclusion criteria. And inreach is like behavioral health referrals or looking at their work queue. So that's kind of how we reach our participants. Mhm.
And then I have a question that's sort of both for you, Cassandra, and for the Sam and Virgil tag team, that you guys actually brought up in your slides about like the role of political uncertainty. I'd be curious to know what role you think that has in your research on substance use disorders, and then for you, Cassandra, how that plays an interesting role in recruiting individuals with marginalized identities that are perhaps even more marginalized these days into research, collecting a lot of information on them, if that's an issue for you at all. Very curious about both of those.
You know, one area that I'm very interested in is seeing how that impacts the workforce and mental health. So clinicians who are seeing individuals for SUD and using digital CBT, and those individuals using those substances out of due to anxiety, stress, or fear surrounding the political environment that they're in, and implications that would have also on the worker, especially if they're located in that region and area too.
Yeah, and I think, yeah, like going on your question of is it difficult to collect data on them? I think with how times are right now, we have been seeing that it is more difficult to recruit participants, and getting them to answer calls just to screen them has been also something that we've been dealing with. But yeah, we try to collect as minimal data that we can on them as possible, just and then also make sure that we let them know that this is like a legit study, it's nothing that we're trying to scam them, because they too tend to be more skeptical of these kinds of things, because it's just like not something that they fully understand. But yeah,
Yeah.
it is.
And that the integrating within systems that already exist and that these individuals are already engaging with is such a useful thing to leverage.
Mm. Mm.
Yes, I see the message in the chat about funding for particular disorders being completely cut. It's certainly a
Yeah.
very, very challenging time to be doing some of this really important work.
Definitely.
Any other questions that folks in the audience might have for any of our 4 speakers, 3 presentations? So if not, we can have an additional couple of minutes break before networking. Special interest groups. All right, well, thank you everyone for joining. Big thanks to all of our speakers. Really enjoyed hearing all of your research, and I hope everyone enjoys the rest of the conference.